I think over the years, one of the studies that has been most compelling, as I think about all the children with SMA, were the studies done out in Utah by our colleague Kathy Svoboda, where she had the opportunity to follow on a weekly basis some children who were known and diagnosed prenatally to have SMA, to follow them and look at their physiology, as you say, the neurophysiology of the compound muscle action potential amplitude and a motor unit number estimate on a serial basis, even before they had any clinical symptoms. And obviously at that time, she had no clue whether these children were slated to be infantile onset or later onset, but she followed them nevertheless. And I think that the curves that she has published, which showed so clearly that the fall in the amplitude of the motor response and the estimate of the numbers of motor units occurred so clearly well before the clinical symptoms appeared, I think is one of the things that has really been on my mind as we begin this new era in spinal muscular atrophy where we can talk about potential treatment. Because if in fact you've had an exponential loss of your motor neuron numbers prior to onset of symptoms, just trying to be very astute and come up with early clinical diagnosis may not be enough. And so I think this has led to what many of us have been involved with, is trying to discuss and promote the national effort to do newborn screening for spinal muscular atrophy. As we all know, this did pass through the committee that makes recommendations of newborn screening practices to the Secretary of Health and Human Services, but this leaves still in our country the process being still quite cumbersome and complicated, in that each state has to create their own method for doing newborn screening. So even though there are a few states now that have voluntary or pilot studies ongoing, it's certainly not something that is widespread quite yet. But I think it's very much worth talking about even before we finish this section on diagnosis. What are your thoughts about newborn screening?
So newborn screening, I think, has been hugely exciting to see. As we'll talk about with the new treatments, the earlier we start treatment is the biggest key to kind of seeing what these outcomes look like. So we're all very excited to kind of have newborn screening start, and really every couple of months it seems like there's another state or two that's added to the list. So while it's quickly expanding, it does take time to kind of get widespread. When we do this, it's interesting because we will pick up on a lot of patients that potentially we wouldn't have otherwise met for many years. So in general, the newborn screening is only screening for the deletion in SMN1. So that's important to know because we are missing the point mutations. So there will be some patients with 5q SMA that will get missed on the initial newborn screen.
And what fraction would you estimate that to be? That's going to be about
3 to 5%,
right.
I think, is where all the papers have kind of shown that to kind of fall in. So that will be an important thing to kind of remember, and it may make the diagnosis harder because there will be fewer of us that will be used to seeing that acute disease, the same way we have a harder time diagnosing measles these days. The other thing that it will find is that it will give us kids who have 1 copy of SMN2, 2 copies, 3, 4, even more than 4. And so that's going to produce kind of interesting questions about when we initiate treatment kind of going forward, particularly for those patients with a higher SMN2 copy number. There's some recent guidelines that came out about newborn screening and the initiation of treatment. And these are kind of expert guidelines from a group of people sitting in a room with pretty much a universal recommendation that any baby with 2 or 3 copies that chances are would be a type 1 or type 2 infant should be offered treatment at birth. But once you get to those that have 4 or more copies and that may not present symptomatically for quite some time, there's a little bit more debate. And I think those are going to be continual challenges for us to kind of address going forward.
Basil, I think you have strong views with regards to 4 copies and treatment.
Yes, during these discussions regarding how we're going to treat babies who are born with different copy numbers, SMA2 copy numbers, as Liz said, there was consensus in the area of 2 and 3 copies. Because babies who have 1 copy of SMA2, they have SMA type 0. And as you know, they have prenatal onset. The vast majority are really very impaired. And therefore, everybody felt that perhaps treating those babies is not necessary. But that will be left at the discretion of the neurologist, because maybe there will be exceptions to that. There might be a few babies who are actually stronger than expected for type 0. Now, coming to the group of babies who have 4 or more copies of SMA2, we did not reach consensus, because some of my colleagues felt that we can follow these babies clinically or by using electrophysiology periodically and following their CMAP values and try to find early signs of the disease and then treat if the child seems to have signs of SMA. Myself and some of the other colleagues, we felt that these approaches are not very accurate, given that the physical exam is not totally reliable. It could be that some signs could be misinterpreted, or it could be that the follow-up is not as close as supposed to be. And also following CMAP amplitudes, is subject to technical issues, and it's possible that that you may not detect reliably a reduction in the CMAP amplitude for different reasons. So we felt that we should probably treat even the babies who have 4 or more copies of SMN2, because again, the detection of disease onset is not very accurate, and by the time these babies develop those symptoms and signs or electrophysiologic findings, by then they've lost a significant number of motor neurons, and I don't think that that would be acceptable if it's totally preventable. So again, there was no consensus, and therefore this area is still debated.
I think the issue of newborn screening would probably be very reasonable for us to circle back to once we have had a chance to talk a little bit about the treatments that are emerging, because I think that those points are very, very valid.